Oh, now the message has come.
Medal, could you please share the screen? I think we can get it started.
Start the program anyway.
Yes, sir.
Sorry. Just getting time. Meryl, Ekam, Meryl, Joy. Start.
So good afternoon, everyone. A very warm welcome to all the faculties and participants who have taken their time out and joined us for today's webinar. ACOM Foundation, in collaboration with OGSSI and UNICEF, have come together in presenting this webinar series on Makes Pregnancy Safe for frontline health workers, focusing on skill upgradation on this core subject. We are very happy and proud in introducing our panelists for today's webinar, moderated by Dr. N.S. Iyer. And our key expert speakers for today are Dr. Shanti Gunasinghe, Dr. Vijaya ma'am, Dr. Sampath Kumari ma'am, Dr. Vijay Lakshmi ma'am, and Dr. RSS sir will be addressing the webinar on day 2. So let's start the program with the Tamil Thai Varthu.
Yeah, Meryl.
Yes. So thank you. Next, may I invite Dr. Shanti Gunasinghe ma'am for the prayer song.
This is our OGSSI prayer. So thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessing to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn, the courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you.
Thank you, ma'am. It is an immense privilege to introduce and welcome Dr. Iyer to moderate this session and who will also give an introductory note of the webinar. Dr. Iyer is a retired senior obstetrician and gynecology of Kerala Government Services. He was a former project officer of the Health and Nutrition UNICEF Chennai. He was also the former national trainer on emergency obstetric care, FOXY AMDD program. He received the Best Doctor Award in Kerala Government Health Services in 2000. He has also received a Lifetime Achievement Award from the Government of Tamil Nadu for the training several batches of newly recruited doctors and staff in Tamil Nadu on ECMO. He was the first one to introduce the non-pneumatic anti-shock garment in India. Over to you, sir.
Thank you very much, Meryl. And welcome to all participants, and welcome to Enchanting Tamil Nadu for the participants outside Tamil Nadu. And welcome to all the esteemed faculty members also. And also the audience. I think most of the audience are the frontline service providers or the backbone of the maternal care, I may say. They're actually working behind the scene as far as obstetrics and newborn care is concerned. And as the PSC medical officers and staff nurses are first line of contact on any emergency situation, there cannot be any limit to their capacity building and improving their skills. It is indeed a welcome gesture that OGSSI has readily agreed to be part of this joint venture with UNICEF for a series of training programs with interactive sessions between the frontline service providers and eminent obstetricians and neonatologists in Chennai. So even though the government staff undergo in-service training, and I'm not sure whether these staff nurses and other staff working in the private sector are getting any in-service training. And I think this will be beneficial to all the staff nurses who are participating in the training program. And it is also, the time is a bit limited. And if interest is shown by a lot of people, we will be ready to arrange more and more such training program with giving more time gap. So welcoming the faculties once again, and over to Meryl to introduce the first speaker of the session.
Thank you, sir. It is an immense privilege to introduce and welcome Dr. T.K. Shanti Gunasingh ma'am for the talk on the antenatal care. Dr. T.K. Shanti Gunasingh is a practicing gynecologist with an experience of 33 years in her field. She's completed her MBBS and MD from Madras Medical College. Dr. Shanti is also a past president of OGSSI, the former director and superintendent of Institute of Obstetrics and Gynecology, Chennai, the former director and superintendent of ISO KG-KKK, and also the former HOD of the Obstetric and Gynecology Department of Kilpack Medical College. Over to you, ma'am, for the antenatal talk.
Thank you, Meryl. You have to stop sharing, isn't it? Then only I can share.
No, ma'am, it's a multiple sharing screen. You can.
Then I should press the share screen.
Yes, ma'am.
What must download?
You can press the sharing screen and then you can give the multiple sharing option and then you can do it.
What's happening? Meryl. Speaker on. Speaker unmute பண்ணு. Speaker.
Can you see my presentation? Yes? Meryl? Can you hear me?
Yes, ma'am, I can hear you. But I'm not able to see the screen.
Can you see my screen?
No.
We are not able to see it still, ma'am.
Your screen sharing.
You are screen sharing, it is written. And
Yes.
like, yeah, then.
Do you want me to stop the screen and then you can share it?
Yeah, that will be better, I think. You stop share.
Yeah.
Yes, ma'am. Screen is free.
Yes.
Can you see now?
Yeah,
Yes,
yeah.
ma'am.
Okay, fine. So, Good afternoon to one and all. The topic given to me is antenatal care. So what is antenatal care? It is a systematic care provided by skilled healthcare professionals to pregnant women to ensure the best health conditions for both mother and baby during pregnancy. So it has three pillars: risk identification, prevention and management of pregnancy-related or concurrent diseases, health education, and health promotion. So the main purpose of 2016 WHO recommendations for antenatal care is to put the woman at the center of care, promote innovative evidence-based approaches to antenatal care, enhance the women's experience of pregnancy, ensure that the babies have the best possible start in life, aligned with sustainable developmental goals. So it's not just survival, but we expand it further, that is care beyond survival too. And it will complement existing WHO guidelines on the management of specific pregnancy complication, and it promotes a human rights-based approach to care. So the main thing is reduction of maternal and perinatal morbidity and mortality and a positive pregnancy experience. So focused antenatal care is an entry point to other critical services too, like tetanus prevention, sexually transmitted infection prevention and treatment, prevention of mother-to-child transmission of HIV, tuberculosis detection and treatment, birth planning and complication readiness, skilled attendance at birth, family welfare services, and child health. So actually, antenatal care starts preconceptionally itself, especially in high-risk women. So folic acid supplementation, 400 micrograms, should be considered for all women aspiring to become pregnant 2 to 3 months before planning pregnancy. And we have to consider a higher dose, 4,000 microgram, that is 4 milligram, in women who are taking anti-seizure medications and drugs that interfere with folic acid metabolism, who are obese, and who have a previous neural tube defect. This indeed reduces the occurrence of neural tube defects by 2/3. Hepatitis B vaccination for at-risk women to prevent transmission of infection to the infant, HIV/AIDS screening and treatment. This allows for appropriate treatment, and this also helps the couple regarding the timing of pregnancy and treatment. Screening and treatment of sexually transmitted diseases. So this will actually reduce the risk of ectopic pregnancy, infertility, chronic pelvic pain, fetal death, physical and developmental disabilities, and blindness. Rubella vaccination is mandatory, which will protect against congenital rubella syndrome. Optimizing weight in overweight and obese women. That is very, very important. This will reduce the risk of neural tube defects, preterm delivery, diabetes, cesarean section, and hypertensive disease. Smoking cessation. So this will prevent smoking-associated preterm birth and low birth weight. And passive smoking also should be prevented. Eliminating alcohol use before and during pregnancy, which will prevent fetal alcohol syndrome. Anti-epileptic drug use. So, sodium valproate seems to be a very common anti-epileptic. It has to be changed to less teratogenic drugs like lamotrigine. And diabetes mellitus, the hemoglobin A1C should be maintained less than 6, not 7, to decrease the congenital anomalies, NICU admission, and long-term health consequences in the infant. Hypertension, it is very, very important to avoid ACE inhibitors like enalapril and captopril, and ARBs like losartan. So these would have to be changed to better drugs. And if there is long-standing hypertension also, we have to assess the end organs, renal disease, ventricular hypertrophy, and retinopathy, correct all those, and then only embark on pregnancy. Hypothyroidism, the thyroid level, she should be euthyroid with drugs. Hyperthyroidism, It is better if she is on propyl thiouracil in first trimester and adequate control of asthma. And suppose she is a systemic lupus erythematosus, at least 6 months of quiescence on stable therapy, then only she should aspire to become pregnant. This will decrease risk of hypertension, preeclampsia, preterm birth, fetal death, fetal growth restriction, and neonatal lupus erythematosus. So in the booking and or the first visit, what do? Nutrition and diet, counseling about that, identifying high-risk factors, plan antenatal care and place of birth, detailed history, physical examination, investigations like urine routine, urine culture and sensitivity, blood grouping and RH typing, complete hemogram, HIV, HPSAG, VDRL, serum TSH, screening for GDM with a 2-hour post-glucose blood sugar, after 75 grams of oral glucose, and we have to screen for asymptomatic bacteriuria too, and indirect Coombs test if mother's negative and father's positive. So the booking visit should be as early as possible, at least by 12 weeks. That is Government of India recommendation, but we would like to have it even earlier, which that will be really helpful for the mother. Ensure privacy, make the patient comfortable and relaxed, maintain confidentiality and establish rapport. Pregnancy has to be confirmed at first visit. So many times they will come with amenorrhea, even a TT would have been given. But it is important to confirm pregnancy. Record all facts on mother and child protection card. This card is really very good. From conception till the end of immunization, the early immunization is noted in that MCP card, and highlight abnormal findings. As healthcare providers, it's always good to carry a red pen so that we just underline any high-risk factors. So it just catches our eye when she comes for subsequent visit. So history taking is very, very vital. And we have to start with the age of the woman, order of pregnancy, birth interval, LMP, and calculation of EDD. We have to ask for symptoms of pregnancy: nausea and vomiting, heartburn, constipation, increased frequency of micturition. Ask for symptoms of complications like fever, persistent vomiting with hydration, dehydration, palpitation, tiredness, breathlessness, swelling of legs, face, etc. The obstetric history should be elicited: number of previous pregnancy, time, mode, outcome, and any past obstetric complications. So many obstetric complications tend to recur in subsequent pregnancy too, like history of PIH, PPH, preterm labor, and any current or past systemic illnesses, hypertension, diabetes, heart disease, epilepsy, asthma, jaundice, and family history of systemic illness. So if there are family members have diabetes, hypertension, invariably the woman might also develop these diseases during pregnancy. And as I told you earlier, intake of alcohol, tobacco, smoking, drug intake, allergies. We have to inquire about domestic violence. So general physical examination, we have to look for pallor, jaundice, pulse rate, respiratory rate, fetal edema, blood pressure, and now SpO2 has become part of vitals, fifth vital, weight, thyroid, and breast examination. And in that, recording BP is very, very important. How we record is very vital. Patient is comfortably seated, legs uncrossed, back and arms supported, appropriate cuff on upper arm, hand at the level of midpoint of sternum. So that means at the level of right atrium. She should relax, should not talk for at least 5 minutes before recording BP. And the most important thing is we have to record the BP initially by palpatory method and then only by auscultatory method to prevent the auscultatory gap. So abdominal examination monitors the progress of pregnancy, fetal growth, fetal life, presentation, and fetal heart sounds. So fundal height is assessed after the patient voids urine and correcting the dextrorotation of uterus. So GA in weeks, gestational age, corresponds to fundal height in centimeters from 24 weeks to 32 weeks. And if there is an increase in fundal height, we know that it can be wrong dates, multiple pregnancy, hydramnios, tumors complicating pregnancy, anomalies of the fetus like hydrocephalus, vesicular mode. And decreased fundal height can be there in oligohydramnios, fetal growth restriction, wrong days, intrauterine death, and transverse lie. Obstetric examination is very, very vital. And fundal grip, we should go methodically. Fundal grip for lie and presentation. Then the umbilical grip for locating the fetal back. Then the first pelvic grip determines the presenting part, whether it's mobile, unengaged, or engaged. And the second pelvic grip determines the degree of flexion of the presenting part. And auscultation of the fetal heart, either by a step or ideally by a Doppler. That is most important, because then we also note the heart, and the patient and our attender also listen to the fetal heart and get reassured. And that when we are seeing fetal heart, it is important to palpate the mother's pulse. Sometimes when she has tachycardia, we can easily underweight or start of BMI less than 18.5, we have to aim to gain 12.5 to 18 kgs. So it is not like earlier when we used to say 9 to 12 kg. We have to really individualize the gestational weight gain according to the previous BMI. And women who are normal weight at the start of pregnancy, BMI 18.5 to 24.9, 11.5 to 16 kg. So for Asians now, this 24.9 has become 22.9. Anybody over that are overweight women, and these women should aim to gain 7 to 11.5 kg. And obese women, BMI more than 30, should aim to gain 5 to 9 kg. This is very, very crucial. And the lady should really attempt to gain the optimum weight gain, so that she will have good maternal and fetal outcome. If there is increased in weight gain, then she can develop diabetes and hypertension very easily. And counseling on healthy eating during pregnancy is very, very important. What is needed is only 300 kilocal per day in the second trimester and 400 kilocal per day in the third trimester. And the carbohydrate should be about 175 grams per day. Protein intake should be more, 1.1 gram per kg per day. So this is the pregnancy plate, and we should advocate at least, encourage her to take fruits at least 3 to 5 times per day. And fruit juices should be avoided. Iron-rich foods like soya bean, eggs, chicken, green leafy vegetables should be encouraged. And for our setup, probably we can ask them to take gooseberry after each meal, so that the iron in the food is better absorbed. And drumstick leaves and drumstick, actually they are a good source of iron and of protein too. So we give folic acid and B complex in the first trimester. And generally in the Western world, iron is not routinely prescribed. But as per WHO, a daily oral iron and folic acid supplementation with 30 milligram to 60 milligram of elemental iron and 400 microgram of folic acid is recommended in pregnant women to prevent maternal anemia, puerperal sepsis, low birth weight, and preterm birth. But our government of India actually, where we supply tablets which contain 100 milligram of elemental iron and 500 microgram of folic acid, and it is given from 14 weeks for about 100 days. So this is prophylactic dose. If she is found to be anemic, Then she will be switched over to therapeutic dose, which will be twice a day. And what about other dietary supplements? So calcium, actually WHO says that in populations with low dietary calcium intake, daily calcium supplementation is recommended for pregnant women to reduce the risk of preeclampsia. So our tablets maximum contain only 500 milligrams. So, and usually iron and calcium should not be taken together. So in women who are prone for preeclampsia, higher dose of calcium should be given. And WHO does not recommend routine vitamin D, but RCOG recommends supplementation of vitamin D. And this is a paper from AIMS, New Delhi. And here, this is from India. So the incidence of vitamin D deficiency in pregnant women ranges from 67 to 96%, which is quite huge. So probably there is a role for vitamin D supplementation. DHA supplements do not improve cognitive outcome in offspring. Vitamin A supplementation may be required in areas of severe deficiency, which is not usually seen in southern states. Vitamin E, C, B6, zinc, and other micronutrient supplementation is not recommended, but T6 pyridoxine, intake of fat, ameliorates vomiting of pregnancy to a certain extent, and deworming with albendazole in the second trimester. And exercise in pregnancy is safe for both mother and baby. She can continue to work till delivery. She can travel by air, train, and car, which is quite safe. Air, she can travel up to 36 weeks, but long duration of travel might precipitate venous thromboembolism. So in this COVID times when we do not have enough trains, people resort to flight, so we should be able to counsel them too. Sexual intercourse not known to be associated with adverse outcomes. Screening for sickle cell disease and thalassemia should be offered to all women as early as possible in pregnancy as per RCOG. In India, we do not routinely look out for sickle cell anemia and thalassemia, but then in hilly areas where sickling is very common, in those areas, of course, routine sickling test is being carried out. And thalassemia also, when a complete blood count is done, then to a certain extent it can be suspected. And pregnant women should be registered early in pregnancy and pick me number to be given. For pregnancy, infant, cohort monitoring and evaluation, this is done by the government for all patients who are going to deliver in government as well as private. And women should receive the benefits of Dr. Muthulashmi Reddy maternity benefit scheme if eligible. Knowledge about Janani Suraksha Yojana should be imparted, thus promoting institutional delivery. And utility of 108 and 104 should be emphasized. And what about ultrasound in antenatal care? So ideally, screening for Down syndrome at 11 weeks to 13 weeks, 6 days is the first recommended scan. This will tell us about the gestation age, early anomalies, and for Down syndrome. But so many times, early ultrasound scan from 6 weeks can be done to determine location, number, and viability in high-risk pregnancy and pregnancy with complication. Suppose she is bleeding, then we have to rule out ectopic. Suppose it is over-distended uterus, that is, instead of 6 weeks, it is 12 weeks. Then probably it is a multiple pregnancy. So we have to decide about the chorionicity too. So combined test should be offered to screen for Down syndrome from 11 weeks to 13 weeks, 6 days. And for women who book later in pregnancy, triple or quadruple test should be offered between 15 weeks and 20 weeks. An anomaly scan should be done between 18 weeks and 20 weeks, 6 days as per RCOG. But in India, termination of pregnancy cannot be done after 20 weeks. So it's ideal to do it before 20 weeks. And growth scan should be done at 28 to 32 weeks. But then We have to scan in special situations as and when the condition warrants. What about vaccination in pregnancy? The National Immunization Schedule talks about only TD vaccination early in pregnancy, second dose 4 weeks later, but then TD is ideally given from 27 to 36 weeks. So this is not given in government, but given in private. This will really enhance mothers' waning immunity against pertussis and passively protects the infant up to 2 months. And routine influenza vaccination is recommended for all women in any trimester just before the start of influenza season. In Chennai, it is a monsoon time now, and after that, we will see a peak. And women, if they contract influenza in pregnancy, then that results in severe influenza requiring hospitalization. WHO has recommended universal hepatitis B vaccination and other travel vaccines if indicated, like yellow fever, polio, IPV, typhoid, Japanese B, encephalitis. These are not routinely given at all, but they are all travel vaccines. If women are traveling to these endemic areas, if they are pregnant, it has to be given. So, what about subsequent visits? The standard, what we have learned is every month till 28 weeks, every 2 weeks till 36 weeks, every week till delivery. More frequent visits in women. Earlier, WHO recommended 4 visits. Now it is 8 visits. First at 13 to 16 weeks. So we will do the first trimester screening for Down syndrome. Second at 20 weeks, anomaly scan can be done. Third at 26 weeks, when we can investigate for GDM. Fourth at 30 weeks, when interval growth can be seen. Fifth at 34 weeks. Then sixth at 36 weeks to see for any late onset fetal growth restriction, 38 and 40. But RCOG says that nulliparous with an uncomplicated pregnancy, 10 appointments, and parous woman with uncomplicated pregnancy, 7. What we have to note is this WHO, 8 visits at least he should have. And in subsequent antenatal visits, we assess the maternal and fetal well-being, inquire about specific complaints, see for the sympathiofundal height, fetal heart, like maternal weight, BP, urine albumin and sugar and hemoglobin. Our government of India recommends hemoglobin in each visit. Screening for diabetes as per DIPSI recommendation at first visit, booking visit we did, then 24 and 32 weeks. But Government of India recommends only booking visit and at 24 weeks. A follow-up of modifiable risk factors like psychological stress, night shift work, lifting of heavy weights, alcohol and caffeine consumption, and smoking. So earlier we used to see for routine breast examination. It can be palpated, but then if there is retracted nipple, then treatment should not be instituted. That is very, very important. Or I mean, because that will really bring down the morale of the delivering woman. And inquiring into domestic or intimate partner violence should be made. And anti-D, WHO clearly states that it can be given at 28 and 34 weeks, but this is in the context of rigorous research. As per Government of Tamil Nadu, we give only postnatal anti-D, and we have to give antibiotics for asymptomatic bacteriuria for 7 days. And I've already talked about the preventive and helminthic treatment at in second trimester. Now, another drug, this also you all should know, that is, if there are certain risk factors like previous history of hypertension, history of hypertensive disease in previous pregnancy, known diabetic, chronic kidney disease, chronic hypertension earlier, probably they will need aspirin 150 milligram from 12 weeks of gestation until delivery. And nowadays, we also note other risk factors for venous thromboembolism, and if need arises, we give thromboprophylaxis in the form of heparin or enoxaparin. So screening for other complications, earlier we used to do for group B streptococcus, that is not warranted, preterm labor not warranted, but then we should really empower the woman to note the symptoms of imminent eclampsia, like severe headache, vision disturbances, severe pain, nausea, vomiting, swelling of the face, hands or feet, or decreased urine output. So counseling after 36 weeks, already we have counseled the place and mode of delivery. We have to reiterate it. And then symptoms of labor and danger signs should be reiterated. Advice regarding breastfeeding and contraception should also be again emphasized. And in any high-risk pregnancy, counsel about symptoms of imminent hypertensive, counsel about symptoms of imminent eclampsia. We should know that labetalol is a drug of choice. Magnesium sulfate should be started in severe pre-eclampsia, imminent eclampsia. Anemia should be identified by clinical examination and doing hemoglobin in each visit, treated with therapeutic dose of iron sucrose, Paxil as per hemoglobin. Heart disease, assessment of dyspnea and treat the cause. All these are, it's a multidisciplinary team which will treat, but as healthcare professionals, we have to note that. And GDM screening should be done, treatment, medical nutrition therapy, insulin injection or metformin, and epilepsy, thyroid disorders, asthma and other complications to be assessed and treated. And post-cesarean pregnancy, we have to look for pulse rate, any tachycardia and scar tenderness. Early effective treatment and early referral will prevent complications and institutional delivery to be promoted. Common symptoms in pregnancy like nausea, vomiting, heartburn, all these things we have to treat accordingly. We have to suggest small frequent meals, low fat, bland diet, high fiber diet, proper posture, then exercise. And we have to, many times patients complain of vaginal discharge. And that is quite physiological in pregnancy if there is no pruritus or foul smell. So to conclude, antenatal care is systematic care provided by skilled health professionals to pregnant women for good maternal and fetal outcome. Prevention, early detection and treatment of complications is facilitated by good antenatal care. Health education and promotion is important. Antenatal care ideally starts preconceptionally, especially in high-risk women. And booking visit, it has to be really followed up. Early booking before 12 weeks is ideal. Detailed history taking, clinical examination, appropriate investigations, dietary and exercise counseling, and supplementation with drugs are important. Vaccination to be done appropriately. Pregnancy symptoms and complications to be looked for and treated. Counseling about lactation and contraception is vital, and we have to promote institutional delivery. So I thank everyone for their patient hearing, and I thank UNICEF and AGM Foundation for giving me an opportunity to share my thoughts. Thank you very much.
Thank you so much, ma'am, for such an informative talk.
That was an excellent presentation, madam. Very excellent and educative and exhaustive too, within the short time given to you. Within the short time, we have covered almost all the topic, and actually every word we could understand properly. And I think this sort of training program of antenatal care should be repeated also. Not only one training session is not enough, and Dr. Shanti has given very exhaustively almost all the things that should be done during the antenatal care. Thank you very much, madam.
Thank you, sir. Thank you.
Thank you so much, sir. And
thank you, ma'am. Very nice. Very nice teaching. All of the ready?
And regarding this, any doubts or anything, if you want, since you have put almost all the things in the, your doubts may be included in the chat box so that it will be answered after the session is over.
Yes, sir. We've collected few questions in YouTube and here also. I'll give a show, share it in the end of the session.
Yeah.
Meryl, please start.
Thank you, Doctor. So next, I call upon Dr. Vijaya, Director of IOG, to talk on the topic intranatal care. So Dr. Vijaya is one of the most renowned gynecology and obstetrician doctors in the city. She has an experience of 36 years in the field. She's completed her MBBS and MD obstetrics and gynecology from the Madras Medical College. She is currently the Director of Institute of Obstetrics and Gynecology, Egmore Hospital. Her area of interest is high-risk pregnancy, infertility, laparoscopic surgeries. Over to you, ma'am.
Yeah, I will introduce the topic. Okay. Thank you very much, Dr. Vijaya, for taking up this topic. And intranatal care is very important because, as we say, most of the pregnancies occur normally. We always say that most of the pregnancies are normal, but all are at risk. All the pregnancies are at risk. We will say patient delivered normally only after the delivery process is over. And we can also say that we should always expect the unexpected thing to happen in pregnancy also. So the intranatal care is most important. And I welcome Dr. Vijaya to give her thought about intranatal care. Thank you.
Good afternoon, everybody. At the outset, I would like to thank UNICEF for organizing this wonderful program, which is a need of the hour, especially the nurses are the principal people who stay in the labor ward for 24 hours with the patient. So the intranatal care is as much as important as the antenatal care. So let me start my talk saying thanks to our Institute of Obstetrics and Gynecology, and I bring greetings from Madras Medical College. And this is where our entire life goes on as an obstetrician. The labor ward complex is the place where we would like to be, even if we are given 48 hours a day.
Slides are not.
Is my slide is visible?
No. Ah, now it is.
Yes, ma'am. It is visible now, ma'am.
No.
Yeah, okay. So the labor ward complex is the place where we would like to stay throughout our life. And you all know about this Lakshya. This is mainly to improve the quality of the labor ward, and which consists of main components of the Lakshya is the respectful maternity care, birth companion, and labor OT cleanliness. You just concentrate. It is not labor ward or the labor room. It is a labor theater. That much of sterility should be there in the labor ward, and you should start early breastfeeding. So the aims of good antenatal care, especially for our staff nurses, is thorough asepsis. That is very, very important. And we should have a healthy mother and a healthy baby at the end of the day. And any complications, we should identify early and treat. That is very important. And it all starts with the casualty. Zero delay. So the casualty should be immediately, all the cases must be attended to. The patient's waiting area where you give comfort to the patient and to their relative as soon as they enter the labor, when they are in labor pain. And always remember, the pre-labor room is as important as a labor room, where the patient will be there till their active phase, and they have to be given the maximum comfort and maximum privacy. And all these IEC materials are very, very important. So the patients are attended then and there. They should know what are the mission of our hospital, the vision, and what are the things that are getting free for them, and where they should contact if they have any complaints or grievances. All those things should be displayed in a very, very well clear documentation. And the labor room should be as clean as it be, very comfortable, and it should be a 3-part labor table. It's not a single labor room board anymore. And the postnatal ward is, my slides are visible? Hello?
Yes, Vijaya. Yes, Vijaya.
Yes, ma'am. Yes, ma'am.
Yes, madam. So the immediate postnatal ward must be as clean as a pre-labor and the labor room ward. And you all, the staff nurses, I'm sure you have all logged in. The arrangements of the trays in the labor OT, the sterile labor bins and trays must be kept very, very neatly. The way you arrange, then we will know you know the subject and you have understood the subject very well. And also the medicine should be very, very cleanly labeled and kept it in a clear, neat container. And also the tray should be separated and arranged in a proper manner. So there should not be any confusion in case of emergency, because everything you put in one tray. If you want a eclampsia tray, you should bring only that tray, which will have all the components of eclampsia. And registers, you all know there are plenty of registers. We maintain more than 100 registers. Everything should be maintained daily and accordingly, so that there should not be any confusion in case of breakdown. And when should you fumigate? How does the biomedical waste should go out? How does the clean linen should come into the labor room? How does the dirty and soil linen should go out to the labor room? Everything is very, very important. And also every equipment should be in a perfect calibrated state with all the emergency contact number of the service engineer, so that you need not depend on the doctors to call for the service engineers. Phone number should be there in each and every equipment. And as a staff nurse, you should always have a concentration on the near expiry register and also the buffer stock register, so that nothing is missed, should go out of your eyes. And then the verbal order register is important. So many times we just give orders through the phone. You have to maintain the verbal order register and the swab register and drug reaction, handing over register, everything you all are already trained. But only thing is now you have to keep it in order, so that anything that statistics is very, very important to see the quality of the labor room. The statistics and the register maintenance is very, very important, especially the liquid waste management, where most of our blood and blood-stained fluid, amniotic fluid mixed, and trays and instruments you are washing out, it has to be treated, then only it has to be sent out, because it cannot be mixed with the normal drainage. So the liquid management is a very, very important point, and so is the autoclave register. You all should know about the signal lock, the change of color, and fumigation. How do you calculate for your labor room? There is a formula. Earlier, when we started teaching, it felt as if it is very, very tough, but actually it is very easy if you go periodically. And also the PWD and electrical problems, you should keep it in a register, so that weekly you can intimate to the head of the institute. You can say these are the things we needed. And all this checklist you have to maintain periodically, the tray list and the departmental checklist. An ambulance, you should always have an ambulance driver's phone number, so that in emergency you need not go in search of him. And the organization of the newborn corner is very, very important, because that is where you prevent the sepsis of the neonate. And biomedical waste management, the utmost important. You all should know which should be put in which of the bin. That is very important. And also the needle stick injury, how to manage, you must know. And the placenta, always it is in the yellow bin. You all know that. And all infectious bloodstained products of conception, everything should go into the yellow, and sharp waste should be go into the blue bin. And the red bin, always gloves and plastics and all recyclable waste. And the washing area should be clean. You have to wash the instruments after soaking it in hypochlorite solution for 30 minutes, and then you have to wash it, dry it. Then you have to follow the fumigation protocol, measure the length, breadth, height of the room. You get a measurement from the civil engineer, and you calculate the dose and keep it, stick it on paper, and then so that any nurse coming into the labor room will know the formula, how much to be dissolved in each time when they fumigate. And the fogging technique, nowadays we use only Eco Shield, and we are not using formalin anymore to the labor room or to the labor theatre, and use the fogging machine. It is very easy. Only thing is you have to close it only for 1 hour. Immediately you can start using the labor room. And CSS signal lock, you all know it is very important. The color should change. So the staff nurse should concentrate and see whether his color changed when it comes from the CSST room. So the neatness and the arrangements, and how do you keep it inside the autoclave, how do you take it out, everything is very, very important. And then after arranging the labor room and the newborn corner, you come to the patient care. And this is the respectful maternity care. Very, very important. We should give proper due respect to the mother, and you should give her privacy and confidentiality. And each and every time you have to update what is happening, because they'll be very anxious. The relatives and the patient herself is very anxious. She won't know what is happening. Why am I kept inside the labor room for so long? So you have to tell, if you are inducing the gel is kept, you will say till 12 hours we will wait and then we will inform you. So periodic updation is very, very important. And birth companion, this we have scored Tamil Nadu in a very, very bigger way after allowing the birth companion inside the labor room. Each mother, whoever she likes, could be a mother or a mother-in-law, to her comfort, she can keep the person with her, so that normal delivery rates are really increased after we have allowed the birth companion inside the labor room. And then an admission, Shanti Madam already said the high risk and everything should have been checked, and the RCH ID is a must to get the birth certificate, and then you have to triage. So if she needs immediate resuscitation, she has to go to the blue, and emergency within 15 minutes, she has to go to red. Urgent means she has to go to the yellow bar, and green means let's urgent, and white is non-urgent. She can wait if she has come for a glycemic profile or if she has come for a growth scan. This patient can be a non-urgent category. So triaging in the labor room is very, very important. And shaving and enema, we have taken that out. There is no more enema, no more shaving is needed. If at all the pubic hair is more, you can clip the pubic hair. And as soon as the patient is admitted, you will do a non-stress test. As a staff nurse, you can't say, I will do only the nursing job, I will clean the room, I will send for CSST. The patient, all this partogram and non-stress, you must know, because in the primary healthcare and in the secondary healthcare, only staff nurses are managing the entire labor room. Only in the tertiary care institution, the postgraduates are monitoring. You know how to monitor the CTG with the basic heart rate and variability and your deceleration. So with each movement, the baby's heart rate has to accelerate. And if there is any deceleration, immediately you should inform the medical officer there is a deceleration, and whether it coincides with the uterine contraction, you should see. And late deceleration always signifies there is a blood flow to the baby is compromised. And when there is a variable deceleration, it is not related to the uterine contraction, then you should think of cord compression. Partogram is a very, very important tool, because with the partogram, we can earlier identification of the abnormal progress of the labor, early referral is possible, because you have to transfer. If you are working in a village or in the primary health center, the earlier you transfer the fetus in utero, the safer for mother and the baby. And the components of the partogram, the first part signifies the fetal condition. The second part and the middle part signifies the progress of the labor. And the bottom part signifies the maternal pulse rate and the maternal output. And you all know the labor is a process of forceful and painful contraction, ultimately resulting in a happy mother and the happy baby. So you should know what is true labor, what is false labor. The true labor is the labor which increases in intensity periodically, and the interval becomes shortened. It will be associated with the show. The cervix will be effaced, dilated. There will be descent of the presenting part. Even if you sedate, the true labor pain does not stop. In contrast, the false labor pain comes randomly. It is irregular. It never increases in severity or frequency. And there is a role of epidural analgesia, where you can start when the patient starts in the active phase of labor, like a heart disease and severe anemia, you can still use an epidural analgesia. The stages of the labor, you all are very, very thorough in your nursing school life and the student life. These are the important questions: the first stage, second stage, third stage, and the fourth stage. In the first stage, you all know there will be uterine contraction, dilatation, rupture of the membrane till such time, and you can have a latent phase or active phase. The active phase is the one where you will start from 4 centimeter to full cervical dilatation. That is the time you have to start the partogram. So you can relax when the patient is in the latent phase. The only thing I want to stress for the nurses is, during the latent phase, the patient can move around. Don't confine her to the labor table, and she can have fluids and juices and light, soft biscuits and soups whenever she likes. No need to be fasting. The patient can be ambulatory. In the second stage, the patient can occupy the position she wants. She can sit and deliver. She can lie down and deliver. There's no need to put the patient on lithotomy for all normal labor. And you all know the second stage consists of the descent, flexion, and rotation, restitution, and extension and restitution. The second stage, the partograph is a must, and you have to monitor the fetal heart rate very, very closely. And if you need episiotomy is not indicated for all normal delivery. Remember that only if you feel you are going to put an instrumental delivery, or if there's a rigid perineum, or you feel the baby is a little bigger, then you can go for an episiotomy. And the timing of the episiotomy is when the head crowns at the vulval outlet, when there is a thinning of the perineum, and there is where 3 to 4 centimeters of the scalp is visible. That is the time you will give a mediolateral episiotomy. And whenever the baby deliver, what should the nurse do? Call out the time and sex of the birth, and receive the baby in a pre-warm towel, put the baby on the mother's abdomen, and discard the wet towel and cover the baby with another pre-warm towel. Immediately put the baby into the breast, and you can slowly clamp the cord. We all advise delayed cord clamping only after the cord pulsation ceases. And then you put an identity wristband, record the weight of the baby, vitamin K prophylaxis, and initiate the breastfeeding of the baby. These are all the things a staff nurse should do. You should not deviate from this. And baby care, you all know the 6 clean hand, clean cut, clean blade, clean cord, clean surface, and clean towel to wrap the baby. And cord clamping, usually we do only delayed cord clamping, but only in certain condition you have to do a early cord clamping when the baby is asphyxiated, when it's an RH negative baby, when it's a diabetes, HIV or HBS ag mother, then you will clamp the cord immediately. Otherwise, you have to wait till the cord pulsation stops. Delayed cord clamping is beneficial to the newborn. So this is the way you should put the baby immediately to the mother's breast. And equipments, you all know how to keep it very clearly, the warmer, whether it is working, the suction apparatus, the weighing machine is working properly, cord clamp, everything should be checked by the staff nurse. And the third stage of the labor is the where the delivery of the fetus to the delivery of the placenta, where you will do the active management of third stage of labor. Very, very important to prevent postpartum hemorrhage. You will give testosterone 10 units intramuscularly within 1 minute of the delivery of the baby to a controlled contraction, and you assess the tone of the uterus. And fourth stage is very, very important. This is where we miss most of the cases. Once the baby is delivered, we immediately move around away from the mother and the baby, and we will start doing the record work and writing the parturition register. But this is the time that within 1 hour you have to monitor the pulse, BP, any bleeding you should check here only, especially for the diabetic baby. This is the time it will go for hypoglycemia. Vaccination in the newborn, in the labor room, you have to give vitamin K prophylaxis, you have to give hepatitis B vaccination intramuscularly in the anterolateral aspect of the thing. This is the staff nurse is giving, so you should be sure it should be given intramuscularly. And also the oral polio and the BCG vaccine also comes in the 0 dose. But in IOG, if the baby is admitted, we will delay the vaccination a little bit. Only vitamin K we are giving. Once the baby is settled, we'll start giving the other things. And these are the few important conditions where you will give a different management. Like in anemia, you will give a back rest. You should have a oxygen. You should have a lifeline. And you should avoid fluid overload. Never allow the drip to run fast. Always keep the mother in a supine and head up position. In the second stage, anemic mother always better to help her out with an instrumental delivery. And third stage of the labor, always watch for failure and watch for postpartum hemorrhage. Hypertension in pregnancy, Shanti Mama already told how to make her BP control antihypertensive. But during labor, always look for any imminent signs and symptoms like headache, nausea, vomiting, and visual disturbances. And watch for the urine output and watch for abruption. And pre-eclampsia, you should all know about magnesium sulfate tray. The eclampsia tray is very, very important. All your labor room, keep an eclampsia tray ready, especially the 20 ml and the 50 ml syringe. That is where there's a problem, because if you load it in 10 ml, 5 ml syringe, it's going to take a longer time. And you always follow the Pritchett regimen. Everybody knows about the Pritchett regimen, so I'm not going into the detail. But what we follow in IOG is the Zuspend regimen, which is very, very easy, because we have an infusion pump where you load 48 ml of 50% Maxelf and give it as 2 ml per hour. It will exactly go as 1 gram per hour. If you have an infusion pump, it's ideal to go for a Zuspend regimen. And cardiac disease in pregnancy, you all the infective endocarditis prophylaxis must always remember in anemia and cardiac disease, the fluid should be restricted. Never ever overload the heart. And heart failure can be managed usually like an oxygen and diuretics. GDM, main thing is if you are going to induce morning, you can skip the dose of insulin, keep the target blood sugar always 100 milligram, and during labor, you monitor the sugar, CBG second hourly, active phase hourly, and then you always anticipate shoulder dystocia because GDM babies are always bigger babies. And postnatal pregnancy, confirm the gestation age and induce labor either with the Foley's or with the prostaglandin E2 gel. So usually we induce labor at IOG at 40 plus 3 days. We wait for 3 more days. We don't induce on dates. And other high risk factors, of course, we will induce. And preterm labor, if the patient comes in preterm labor, you confirm the gestation age, and there is a role of steroids. There is a role of magnesium sulfate for neuroprotection. And the main investigation you should do is urine culture, total and differential count, and high vaginal swab. And preterm labor, you start steroid, either dexamethasone or betamethasone. Nifedipine is the ideal drug of choice for tocolytics. And the neuroprotection is Maxer. This magnesium sulfate is given for neuroprotection of the preterm baby. It is not for preventing eclampsia. And PROAM, again, if you can wait and watch, if the draining stops because of the high rupture of membrane, we can allow them to go till 34 weeks. But if there is a continuous leak of LICA and if there is chorea amnionitis, then you should think of deciding the termination of pregnancy. So this, my last slide, the do's is respectful maternity care. Presence of a birth companion is mandatory. Always provide privacy, and the patient should give freedom to choose comfortable position during labor and adhere to clinical protocols for the management of labor. The IEC should be there throughout labor room and also in the pre-labor room, so that then and there when you walk around, you automatically you will read that. Even if you don't like it, it will fall into your eyes and it will go into your memory. So always keep an IEC colorful inside the labor room and use labor beds instead of labor table. And immediately after delivery, place the baby on mother's abdomen. Initiate breastfeeding immediately. And don'ts, never ever induce or augment without clinical indication. Don't verbally or physically abuse the mother. How much ever tired you are, how much ever emotionally disturbed you are, we should not show our irritation to the patient. Always remember that you have to give proper respect to them, because especially in a government institute where there are poor people, they cannot afford. See, what they expect from us only the comfort and the affectionate words. Periodically update them. Don't shave the pubic hair. Don't ask the patient, insisting on lithotomy. Don't do that. Episiotomy is not indicated. Don't immediately clamp and cut the cord. Don't separate the baby from the mother. Always rooming in, and never ever ask the patient to buy drugs from outside. Don't write and send for drugs and diagnostics. With this, I just thank Iyer sir and also the UNICEF, and these are our pillars, our staff nurses are our pillars. We always form a team. Thanks a lot for the opportunity.
Anyway, an excellent presentation again. And Dr. Vijay has indeed concise and nearly 3 to 4, I may not say 4, it will be more than 6 hours of lecture into 30 to 40 slides within the time slot given to her. It was a great thing, madam. And indeed, IOG has got the state-of-art labor room and labor ward. I am very proud of it, because I had come over there. I used to come repeatedly during the early 2000 and up to 2008. But to keep this IOG having a maximum number of deliveries taking place, the cleanliness, the sterile environment, etc., is a Herculean task. Hats up to you, madam. Very nice. And then the staff nurses are...
Please come to IOG, sir.
Definitely. The staff nurses are included, are indeed, they are the backbone of the maternal care that I always used to say. See, I was more or less a successful obstetrician for 30 years. And you may be surprised to note that I have not seen a maternal death. Don't think that I have conducted only less deliveries. I have conducted more than 25,000 deliveries in my lifetime. But that is I was a bit lucky anyway. But that is another thing. But all these not because of my expertise. It is because of the staff nurses who are working in my labor room. I won't be there in the labor room. It is a responsibility of staff nurses. And instead of asking them calling me, I will be calling them. So, let a pulivar get to pulivar. And the staff nurses are the backbone and they are the pillars of the maternal care. If ever the Tamil Nadu has reduced this maternal death from 1,600 in 2000 to nearly 60 or 70 to now, most of the credit goes to, of course, obstetricians are the pillars, and the credit, of course, goes to the staff nurses also. Hats off to them, all the staff nurses who are hearing this session. And this session, and since being live streamed, Madam has the antenatal care, an excellent one, and this another super one. And all those people who are listening to it, may take since it is being live streamed in the YouTube, you can repeatedly watch. So you can repeatedly watch every slide. You can go through everything, and it is an interesting thing. And I was also very much interested in this program. And thank you very much, madam. And maybe one thing everybody should have noted regarding this compression with the code. Compression with the code maybe looks simple. If we can identify a compression of code during the intranatal period, during the intranatal care, that is a very great thing, Like most of the time, sometimes even the hospitals, only after the baby delivers with a 3 to 4 cord around the neck with the severe fetal distress, and baby may go to fetal anoxia, and so that's a major problem. But if that, and madam was telling that she was passing through that word, I like that word, compression of the cord. That is the most important thing. And also the antenatal part, this first stage partogram, and actually being a tertiary center, they do have give importance to the second stage partogram, but we like to give more importance to the first stage partogram in the primary health centers, where we should give them more knowledge about how to plot a partogram in the first stage. Madam has given rush through it because there was not much time, but we will do something later on. Anyway, thank you very much, madam, for this excellent presentation. Thank you.
Thank you, Dr. Vijaya, for an excellent and informative talk on intranatal care. Now, may I invite Dr. Sampath Kumari. Dr. Sampath Kumari has an experience of 34 years in this field. She has completed her MBBS from Christian Medical College and MD Obstetrics from Madras Medical College and DGO from the Tamil Nadu Medical College. She is a member of the Indian Medical Association. She is a FOGSI Vice President elected for 2022. She is a chairperson of FOGSI Adolescent Health Committee for 26 to 2018. She was a former director and the professor of the Institute of Obstetrics and Gynecology of Madras Medical College. Over to you, ma'am, for the talk on adolescence.
And
thank you, ma. Thank you. Can I share the screen? Yes, sir.
Yeah. So let me say a single word on this adolescent care. Why we put this adolescent health also in this session? Because it is a gray area. The adolescent age is a gray area as far as medical care is concerned. They are neither children, they are not adults. So this stage is very peculiar stage. This is the stage when all the cognitive development, every change in the system occurs during this particular period. And this, especially the girls, they do have a lot of they require some emotional support also. So this is the most important period, and giving importance to the adolescent health, adolescent sexual health, everything is very important. And actually we are preparing girls for becoming a mother, and we should do that also during the adolescent period, and tell them about, because if I want telling most of the experiences of ourselves in our older period, most important period this, and we'll have to see that we give more importance to it. Please listen to the lecture and see how much you can learn about the adolescent health. And welcome to you, Dr. Sampath Kumari.
Yes, sir. Good evening, sir. I'll share my screen.
Yeah. You are. Let's go.
Good evening to all. First of all, I should thank UNICEF, Ekam Foundation and OGSSI for giving me an opportunity to address the staff nurses who are very, as Dr. Vijaya told, pillars of ONG. And thanks to Dr. Iyer for giving me a good introduction. As sir told, the adolescents, they are neither a children nor an adult. அவங்கெல்லாம் வந்து சில்ட்ரன் நினைச்சின்னு அவங்க சொல்றதை நம்ம விட்டுறவும் முடியாது, அடல்ட்டுன்னு நினைச்சிட்டு அவங்க சொல்றதை எல்லாத்தையும் எடுத்துக்கவும் முடியாது. அடலசன்ட்ன்றது இட் இஸ் அ வளர் இளம் பருவம். It is a transition from childhood to adulthood. As per WHO, it is from 10 to 19 years. Adolescents are categorized as early adolescence, middle adolescence, late adolescence. In early adolescence, 10 to 13 years, the development of the secondary sexual characters. In the middle adolescence, 4 to 16 years, 16 வயதினிலே, they are attracted by the opposite poles, opposite friends, boys, girlfriends, everything. And the late adolescence in 17 to 19 years. This is the period they want identity. That is the identity they want. So it is our duty. Why we want to give importance to the adolescents? Now the populations, the Indian population is 22.3% of adolescent. As per research studies, in 2030, it may increase to, or it will be 30 to 35% the population will be adolescent. So I'll divide the topic into nutrition health, menstrual health, and general health. As I told, I'll cover almost all parts of the health in the adolescence within 30 minutes. The nutrition. Why nutrition is important during adolescence? During the adolescence only, 45% of the skeletal growth take place, and 15 to 25% of the adult height is achieved during adolescence in boys and girls, and 37% of total bone mass may be accumulated in adolescence. So nutrition is very, very important during adolescence. For the adolescents, you cannot tell that don't have the fast food, don't have pani puri. So you can tell them that when you address the adolescents, take the fast food monthly once. Don't tell, don't take. You ask them to take the whatever it is, burger or chips or whatever it is, they can take monthly once or twice. Frequently, they should take this fiber diet, fruits, vegetables, nuts, and the sprouts and milk. These are all the things which they should take routinely. And as an adolescent, we cannot ask them to follow the adolescent pyramid. So just like the 3 main meals and 3 snacks. Snacks is, it can be fruits or juices or biscuits like that. And it is not a fast food. So breakfast, lunch, dinner, and the snacks. The total of 1,500 to 1,600 calories per day they should take. The importance of breakfast is very, very important. It should be taken within 2 hours of waking up. The night, throughout the night, we are under fasting. If you don't take breakfast, the glucose metabolism will be disturbed and there will be an increased weight gain. So breakfast, ராஜா மாதிரி காலை உணவு சாப்பிட வேண்டும் என்பது தெரியும் எல்லாருக்கும். அதனால ராஜா மாதிரி சாப்பிடணும் காலை உணவு. மத்தியான உணவு மந்திரி, இரவு உணவு பிச்சைக்கார மாதிரி சாப்பிடணும்ன்றது proverb. Always they used to take. So breakfast is important. The nutrition, rather than that, again, now the incidence of obesity is 40 to 50% with adolescent. Not only with adolescent, everyone. So exercise is very, very important. 30 minutes, whether walking, cycling, swimming, jogging, this can be done for 30 minutes every day. So if a girl is doing a +2, and if you are asking her to go for walking for 30 minutes and swimming for 30 minutes, she may not have time. That to the adolescents, they may not, they have to go to schools, they have to go to the tuition classes and everything. Now they are with the webinar, but still they cannot go out. So we can advise them to have the simple exercises whenever the possibility to climb the stairs, avoid the escalators, and avoid the lift, elevator, whatever it is. And when they go by bus to the schools or car, they can get up in the previous stopping itself, get down. So they can walk for 10 minutes. And when they take the lunch, they can have the walk during the lunch time. So these are all the simple exercises they can do, and they should take up the stairs. So the diet, lifestyle modification, diet and exercise is very, very important to avoid the obesity. What are all the causes for obesity? Main is socioeconomic status. They may not have food and they may not have take the breakfast. And that time also with the stress, they will go to the obesity. And the built environment, hereditary, the mother will be obese and the daughter will be obese. And physical inactivity, sedentary activity, no outdoor games. They have only the indoor games. That will also produce the obesity. And the habits, diet habits. Whenever they like, the adolescent should not take the food. The night 12 o'clock taking the dinner and taking the breakfast at 10 o'clock. They should have an habit of taking the breakfast 2 hours after getting up, and the lunch and the dinner. And the genetic. These are all the causes for the obesity. Why we should bother about the obesity? Because of obesity, what can happen? If the obesity is not reduced, the PCOD, now the PCOD 90% is with the obese adolescent girls only. So the PCOD, if the PCOD is not identified in the adolescents, what will happen? It will go to the gestational diabetes when they get married, and then when they become pregnant, the gestational diabetes. From the diabetes, they will deliver the macrosomia baby. That is, macrosomia is a big size baby, more than 4 kg. So babies for adolescent obesity, again PCOD, again GDM, it will be going on. And with this obesity, if the PCOD is not treated, what will happen? It will go to the insulin resistance is one of the cause, and the metabolic syndrome. So they will have heart disease and a cardiac problem, stroke problem in future. Then this apnea, obstructive sleep apnea, is one of the reasons where we can think of they may have the PCOD. Because of obesity, they will go for psychosocial problems. So that the lifestyle modification is the only treatment for exercise, for obesity. As I told, these are all the exercises they should do. See, if you are going to talk to the adolescents, sometimes they may not like it. So whenever you have an opportunity, you have the colorful posters like this and show these posters to the adolescents, because the nurses, the VHNs, they will be going to the school visits and they will be going to the field visit. Whenever they meet the adolescents, they can show these pictures. And previously, when we were adolescents, the TV, the Dianora TV and solid TV was thick and it was in the table. Now the TVs are thin. The watchers, that is the adolescents who are watching the TV, they are obese. So we should advise the adolescent not to take snacks whenever they watch the TV, because they don't know the amount of snacks they take. So 33 meals, 30 minutes exercise, 3 snacks is the best lifestyle modification. And with the nutrition, the last thing is the anemia. Anemia is a state in which there is decreased production of red blood cells, the decreased concentration of hemoglobin in the cells. Hemoglobin will be reduced. When a girl is doing +2, her hemoglobin should be 12 grams. So the decreased oxygen carrying capacity, because of this, the girl may have tiredness, lack of concentration, hairless and irritability. Among the adolescents now, about 60 to 70% girls and even the boys, 40 to 50% are anemic. Whenever we do the hemoglobin examination in the school visits, more than 50 girls are less than 8 grams. So the main treatment is the iron-rich sources, dates and fish, greens, carrot, beetroot. This should be taken frequently. So you should talk to the girls and the boys to take the iron-rich sources frequently. And the government itself is giving the deworming tablet once in 6 months, and even the folic acid is given to the government school students. So the anemia has to be corrected during adolescence itself. Otherwise, with this anemia, they will get married and they will go for anemia during the pregnancy. And now for maternal mortality, directly or indirectly, for 50 to 60% causes is from anemia. Hope you would have heard the lectures from Dr. Shanti and Dr. Vijaya. So anemia has to be corrected during puberty itself, that is during the adolescence. This is the importance of the nutrition. Next, we will come to the menstrual health. What is happening? The girl should know what is happening in her body. The menstruation, it should be every girl cannot get it once in 28 days. It can be from 21 to 45 days. For an adolescent girl, if she is getting 8 cycles per year, that is more than enough. And the bleeding should be for 3 to 4 days only. If it is more than 7 days, we have to think of any abnormality in the girl. And a girl attains the menarche, puberty, by 12 years. And if she is getting irregular bleeding or she is not getting regular bleeding, means for first 2 years, it may be the immaturity of the HPO axis. So for first 2 years, we no need to bother. After 2 years, only bleeding will be get corrected. Similarly, the age of menarche will be varying from person to person. So normally, as long as 35 days cycle, we can consider it normal. HPO axis, this the girl should know. What is HPO axis? How she is getting bleeding? hypothalamus, pituitary, ovarian axis. From the hypothalamus, hormones act on the pituitary. From the pituitary, FSH, follicular stimulating hormone, and the luteinizing hormone act on the ovary, which produces the estrogen in the early phase and the progesterone in the secretory phase, which produces the withdrawal and leads to the bleeding. When there is a disturbance in the HPO axis, that can be an amenorrhea. If your girl is not getting the bleeding till 16 years and no secondary sexual characters, then she has to be analyzed. And if there is a profuse bleeding, what is the problem? We have to see. So this is the normal menstrual cycle. 1 to 5 days, the bleeding will be present. And then again, the 14th day is the ovulations. After that, it is the secretory phase. Again, the bleeding will be present. This is the menstrual cycle, and the adolescent should know the ovulation. The ovum will come from the ovary only during the 14th day. That is the ovulation. During that time, they may have some pain also. Then the menstrual hygiene is very, very important. Most of the girls in the schools, they should be counseled to change the diapers once in 6 hours. You cannot keep it for 12 hours or 28 hours. If there is the hygiene is not followed, it will lead to the local infections. That rashes will be present in the thigh and rashes will be present over the private parts, and it will lead to the urinary tract infection. And because of this infection in future, first you will have the leukorrhea, and then you can go with the pelvic inflammatory disease, and which will also lead to infertility in future. So the hygiene is very, very important. Now during the corona period, what we are doing, wash your hands, wash your hands. 6 steps, wash after, back, front, tip of the fingers and everything. So before eating and before defecation, urination, you have to wash the hands. And after the defecation, the private parts has to be washed. This hygiene is very, very important. Then about the painful periods, pain during the menstruation. About 60 to 70% girls have pain during the menstruation. They may have the stomach pain, some may have the headache, some may have the leg pain. And this is very, very common for the case of dysmenorrhea. Most of the girls, they don't go to schools. They take leave for once every month, 2 days or 3 days. So we should counsel the adolescents to divert their mind. If they are taking leave and sitting in the home, means again the pain they will be concentrating only on the pain. They should concentrate on their hobbies. And if the pain is not tolerable, they can have mild analgesic with the consultation of the gynecologist or with the consultation of the staff nurses whom you will be meeting them with the adolescent clinic, school clinic and every day. If the pain is very severe, now the incidence of endometriosis is also increased with adolescents. It has to be ruled out, endometriosis. Then you have to consult the gynecologist and what is to be taken. Endometriosis is nothing. The presence of endometrial glands, which is present in the uterus, endometrial cavity may be present in the other parts, normally over the ovary. So these are all the dysmenorrhea has to be identified. Normal dysmenorrhea is nothing. They have to go to schools and they have to take plenty of liquid diet. And the bleeding, main reason for bleeding is anemia. Next, they may have thyroid. Now the incidence of thyroid is present. If the bleeding is more than 80 ml. So if the bleeding is increased before 19 years, it is the puberty menorrhagia, and they have to be consulted to the doctors. Now we have seen, I retired from IUG only. We have seen girls coming to the OP with 4 grams hemoglobin and 5 grams hemoglobin. They will be concentrating only on the studies and they will not be bothered about the health. So the parents should take care, and the puberty menorrhagia has also to be identified in the early stage and it has to be treated. The next common thing is the PCOS. Whether the girl is bothered or not, the parents, they will come, my daughter is having PCOS, whether she can get married and whether she will have children. PCOS is nothing. It is an ill-understood phenomenon defined in various forms over the years. As I told you, with the HPO axis, the estrogen and progesterone, in these girls with PCOS, what will happen? That is with the hyperandrogenism, the free testosterone, that is the male hormones will be increased in the female. So because of this male hormone, because of this free testosterone, which is formed from the ovarian stroma, the girls can have hirsutism or acne, hair growth in unwanted places, and for alopecia, there will be a fall of hair in the front of the neck. And acrocordance, that is a skin tag, will be present near the neck. And acanthosis nigricans, blackish coloration over the neck. And obesity, as I told you, PCOS 90% is from the obese girls only, alopecia and polycystic ovaries. See, most of the time, the girls come with the ultrasound picture telling that it is a feature of PCOS. But with the ultrasound features in the adolescent girls, we cannot tell as PCOS. They should have a history of anovulation, that is irregular bleeding and amenorrhea, or clinical and biochemical features of hyperandrogenism. As I told, clinical is hirsutism, acne, and biochemical features means increased 17. I told you, no, free testosterone. Female hormone is estrogen, progesterone. Male hormone is testosterone. If that level is increased, then it can be considered as PCOS. For to consider as an adult, anovulation, adult PCOS, clinical biochemical features of hyperandrogenism, and ultrasound features. Among the three, any two should be present. But for an adolescent PCOS, all three features should be present. The ultrasound features normally we do through the vagina to see the follicles, but it cannot be done for the adolescent. So with the ultrasound features, don't tell them as PCOS. They should have the bleeding history and the hyperandrogenic features. So if the girl comes to you, tell her the lifestyle modification is the only treatment for PCOS. They have to do 3 meals, 3 snacks, 30 minutes exercise, whatever it is, it has to be done. So if there is an irregular bleeding and amenorrhea, then you can give progesterone, withdrawal bleeding, and then OC pills for 6 months. If hyperandrogenic features are present, OC pills with anti-androgen can be given. Then you refer the cases to us, our gynecologist. So obese PCOS with regular menstruations and no androgenic features, give them only the lifestyle modification, no OC pills. The next common thing is the teenage pregnancy, the menstrual problem. When a girl attains puberty and if she comes with history of amenorrhea, we have to rule out the adolescent pregnancy, teenage pregnancy. Only we should put a leading question to them. What about your bleeding? Whether you have boyfriends? What about your sex? That we should put a leading questions. Otherwise, the girls will not tell. So the teenage pregnancy nowadays, though we talk about the teenage pregnancy, still 10 to 12% of pregnancy, again the teenage pregnancy is present. Why the teenage pregnancy is common? Early marriage, that is school dropouts, those who are not going to the schools, they get early marriage because the parents, they don't want to feed, they get them married. So the teenage pregnancy should be avoided and the pregnancy should take place only after the 21 years. If they get married in the teenage pregnancy itself, what again the complications, the anemia incidence will increase, the bones will not have grown, they will go for CPD, and we talk about increased cesarean section. Again in the teenage pregnancy, the cesarean rate will be increased. And the baby, again, the baby will have problems. Baby will have preterm. Sometimes it may go to IUD also. So the teenage pregnancy should be avoided. Whenever we do the school counseling for the adolescent girls, we have to talk about the contraceptive choices also to the adolescents. Because some girls, they will tell, I have the boyfriend, but I want to postpone the pregnancy. Then we have to give the options to the girls. The girls, now they can have the OC pills, they can have the progesterone injections. Sexually active adolescents, they can have even the copper T. So it is our duty to talk to them about the contraceptive. As I told you about the puberty changes, these are all the changes that will happen with the adrenarche, with the male reproductive system. The testicles develop, a penis growing, and hair growth in the face, chest, and underarms, voice of changing voice, and the production starts in the testes. And masturbation has to be told that it is a normal phenomena and that it is not a disease. We think we should counsel only the girls, the boys, even the adolescent boys, they have a lot of doubts. They don't know about many things. So it is our duty to counsel even the boys, whether it is boys or girls. When they want to tell no, they should tell no. For boys, if the friends compel them to take smoking or alcohol, that boy should tell no. And similarly, if the boy is following her, she should tell that take pleasure and pride in saying no when you want to say no. So don't always ask, the adolescent should not tell yes for everything. When she wants to tell no to a boy, tell her in a polite refusal. She can give the reason that I want to become a doctor and I want to become engineer. I have a lot of ambitions in my life. So after that, we can see everything. So please don't follow him. Follow me. That she can tell. Ignore the person and avoid the situation. and she can get the supports that whom she has the confidence. She may have confidence with the teachers, or she may have confidence with the social workers. And when we do the counseling and we give the phone numbers, she may develop confidence on us, and she can tell so. So you would have seen the movie, Ajit movie la paathirpeenga, no means no, whether even if it is the professional workers. So the girls or boys, they should tell no whenever they want. These are all the habits. We think the smoking, drinking, and drugs are only with the boys. No, now these habits are with even with the girls, and we should tell them the quote the examples. What happens with the celebrities with this habit, smoking, Michael Jackson? What happens with the drinking and drugs? It will lead to the cancers, lung cancer, liver cancers. So we should tell them and counsel that these habits are not good for the body and it should be avoided. The POXO Act. How many of the staff nurses, I don't know, you know about the POXO Act? POXO Act is nothing. If a girl, if has said, that is, it is not only the rape, whatever it is. If the girl, a boy follows him, if he is giving torture or sexually or verbally, whatever it is, if the sexually they are abused less than 18 years, this act is formed. This is formed after the Nirbhaya incidents. All of you must be knowing about the Nirbhaya incidents. That is the gang rape in Delhi. So after below the 18 years, if the rape or whatever incident sexual abuse has occurred, it has to be reported to the police and FIR copy has to be made. So less than 18 years, whether it is married or unmarried, it has to be reported to the police. And if the action, you will think if it is reported to the police, action will be taken later. It's not like that. They have a local committee and if it is admitted to the hospital, they have the local committee and treatment can be given as early as possible. So the POXO Act also you should be aware of. It is very benefits to the girls and the boys, they are also punishable. It is child friendly and then can avail emergency medical treatment. Previously, when the rape case come to the private doctors, they used to refer to the government hospital. It is not like that. As per POXO Act, they have to give the first aid treatment and then only refer wherever they want, and they have to give the FIR treatment. If it is an emergency, for an emergency, if a girl comes with a bleeding, you can give the treatment. Whoever brings it can get the consent. It doesn't mean that only the parents has to bring the cases. The POXO Act is also very, very important and you should know. The stress, next, the boys or girls during the adolescence. Now you should have seen lot of suicidal tendency. Whenever there is a exam results, if they don't do the exam, they commit suicide, and again the love failure. Nowadays the love failure suicide is reduced, I think, because they know all this. For a stress, we used to tell whenever they are under stress, they should not make any decision in depression and anger. So you do the school counseling. When you do, whenever you meet an adolescent, when you go for a school visit or when you go for a home visit, the adolescent should be examined with this method. That is, this is EDS method. EDS is HEADSCS. Home, you talk to her about the home. How many of them are home in their house, whether the father, mother, then you can know what is the food she is getting. If she is in a family with 10 members, what is the type of food she can get, and education, whether she is going to school or not going to school. School dropped out means they will go for even the early marriage. Then the activities you can ask whether they are going for outdoor activities, whether they are playing only with the cell phone, and whether they see only the media effect and the no outdoor game, means the obesity will be present. Then the drugs, you put the leading questions, whether you have the drug habits, or if it is a boys, whether you have a smoking. Like that, if you put a leading question, you can sort out all problems for the adolescent. And whether you have the boyfriend, whether you have had sex earlier, you will think that these are all not necessary, but most of the girls and boys, they know about this sexual activity and whether they have attended suicidal activity earlier. So adolescents should be, when you meet one adolescent girl or boy, all these questions should be made out. If she is coming for a bleeding and if she is coming for the PCOS effect, only if you are going to ask that, the other problems will not be solved. So you put a leading question about all this HEDAS method and take out all problems of the adolescent. Then the media, now most of them, they are very, very with the smartphone or cell phone, or they get information and messages mostly from the phone. So the girl or boy, they should talk should be friendly to the parents. Rather than counseling the adolescents, you should counsel even the parents. The parents are the first friend to the girl or a boy. So they should learn everything. If you are thinking that we should not talk about the sex means, they will learn from the media and they will learn from the cell phone and they will make an attempt to try that. So the teachers, the parents should talk about the nutrition, the menstrual health, sexual health, and the mental health to the adolescents rather than knowing from the media. Then finally, the vaccination. What are all the vaccination the adolescent should have? That is 2 vaccines, the rubella vaccines. In spite of usually we think when there is a congenital anomalous baby is born, it can be a diabetes. Again, the congenital rubella syndrome, again, anomalous babies can be given. So during the adolescence, the rubella vaccine should be given, and 2 to 3 months, they should not become pregnant. That if it is, they were married. And again, the incidence of cancer cervix is increasing nowadays with the girls. So to prevent this cancer cervix, most of the 40% common causes human papilloma virus, habitual multiple partner, early menarche, menopause, that is all the other causes. Human papilloma virus is causes for the cancer cervix. So the HPV vaccine should be given to the adolescent. That is the 3 doses, 0 month, 1 month, and after the 6 months. So these are all the 2 vaccines that can be given to the adolescents during that adolescent period. So now we have dealt about the nutrition health, the menstrual health, and general health. Now this is the challenges that is with the adolescents. 45% adolescent girls are undernourished and 20% boys. We talk about the early marriages. Still less than 15 years girls, 26% get married, and less than 18 years, 54% gets married. We are thinking we should not talk about the sexual health to the boys and girls. 20 to 30% adolescent boys are sexually active, and even girls 10% are sexually active. And 59% know about the condoms, and 49% of adolescents know about the contraceptives. This is the statistics. So you have to give counseling. What are all the contraceptive available? And 4.5% are drug abuse, and 50% HIV positive new infections are with the adolescent group. Then the next is the adolescent abortion again. If the adolescent girls, as per POXO Act, you should make entry, and it doesn't mean that you should treat that abortions. You have to treat, even you can give the emergency contraceptive pills even for adolescent as per POXO Act. So you have to give the easy pills if she comes with a history of rape, and you have to rule out pregnancy, and you have to rule out the HIV cases. Then this is the 10 core for life skill. For an adolescent to have a life skill good, self-awareness, they should be aware what is happening and what should they decide, and empathy, what are they happening, and the critical thinking, whatever thing, they should be in a position. Now, you should have seen in the media, I think, in a Pollachi school, the school boys, with the water can, they have made it as an urinal. Since there is no restroom in that school, with the water can, these boys have made a creative idea and made it as an urinals in the schools. That was reported in the papers also. The critical thinking, creative thinking should be started. And the decision making, yes or no, which I told you, that they should make a decision until no. And the problem solving, how to solve the problems. If they are not able to solve the problem, ask them to get the help of the staff nurses. The nurses you will be going, get the help of the parents, help of the social worker, whatever it is. And effective communication is important. And they should know to live, that is cope up with the stress and the emotions. These are all the 10 core for an adolescent. So we should handle the adolescents very, very carefully. Adolescents are like a glasses. If you handle them very carefully, you can have beautiful things. And if you don't handle them carefully, it will be broken. So all nurses, I think most of the, I don't know how many of the staff nurses have participated. Whenever you meet an adolescent, please talk to them, give them privacy, and talk to them and ask about whatever I have told, the menstrual health, the nutrition health, and the sexual health, and make the adolescents, today's adolescents are tomorrow's world. So our adolescent health is important for nation's health. Thank you. Once again, I thank the UNICEF and the ECOM Foundation and OGSSI for giving me an opportunity. Today's pride, tomorrow's world. Thank you.
And Thank you, Dr. Sampat Kumari. And what shall I say? It is an exemplary presentation. It is impeccable. That is excellent, ma'am. And outstanding, I may say again, because you have covered almost all the topics. Just as I said, Dr. Vijay covered 6 hours topic in 30 minutes. Similarly, you have also covered almost all the topic. This is not enough, madam. Every slide is a teaching. Every slide of ours is a very excellent teaching, especially as I said in the initial stage, it's a gray area. Most of the people doesn't know so many things. Even highly educated people, even the PCOS is a common problem. And they say, now I am not doing any practice, but I get a lot of phone calls. Say, I always do. All my friends, all my old patients, they all call me by phone. Everybody says, sir, PCO. Somebody says, I have got a chocolate. I have got a chocolate in my abdomen. That's a chocolate cyst. So almost all these things, they are all talking about PCOS is a major problem. And also this teenage pregnancy and becoming pregnant before marriage, because these are all not the present social exposure. It was there even when I started my practice in 1971. I had seen girls coming with unmarried girls coming for abortion, and I started practice in 71. We don't say that the social, all these things are main reason for the present situation. It is not so. It is there everywhere. But the problem, another problem is we should have a adolescent checkup, because in Western countries it is a mandatory. It is all the adolescent girls should undergo a checkup. That is most important, because in the villages there are so many people, so many little people, they doesn't know anything about this endometriosis. I had a girl who got married, and in 1974 or 75, who got married, and immediately after marriage she was divorced. Her husband brought her to me saying that she is 5 months pregnant. And they had gone to somebody else, and they found that she has got a 5 months size uterus. At that time, there is no scanning, everything was not so important at that time. But when I found that uterus cavity was normal, so I could find that it's a case of endometriosis, adenomyosis. And for 5 years, she was having this adenomyosis. Otherwise, this uterus would not have become 5 months. So what I feel that we should have a special adolescent checkup, mandatory, then for almost all the students, because we are doing it, but it should be made mandatory. And everyone has understood why we had included this adolescent care also in this session. And it was indeed another impeccable, exemplary presentation. And thank you very much, madam. What shall I say? Thanks a lot.
Thank you, sir. Thank you.
Thank you so much, ma'am, for that excellent talk on adolescent health. Indeed, it was very, very informative. And I hope, our health workers also benefit out of your talk.
Yes.
I think by this, we come to the end of our webinar, and the forum is open for discussions now. We have few questions from the audience, and we have uploaded it in the chat box. So I think the doctors can actually address to the questions regarding the one put in the chat box.
Yeah, I think the first few questions were put for Dr. Shanti on how to measure in EDD, and second one was why we administer the folic acid from the first trimesters. These are two questions that
I saw 3 questions.
Yeah,
so
I think one more on the vaccination. Yes.
So first one is by Negley rule. So this is only for regular periods we can give an EDD. And if it is irregular, it has to be corrected accordingly, and we can give only a corrected EDD. So even up to 35 to 45 days, then 35 days, it would be okay. So you add 7 days, go back 3 months. So suppose if the LMP is November 10th, then you add 7 days. So that will be November 17th. Then you go back 3 months, that will be August of next year. Or else you can add 9 months and 7 days. That will be very tedious. We can easily get missed. So add 7 days, go back 3 months. And that will be in the next year. Okay. So 2021. So November 10th means November 17th. So go back 3 months is August 17th. So August 17th of 2021. So that is the first one. And the second one is folic acid, not only in the first trimester, that is earlier even, I said preconceptional even, 3 months prior to that. And that is very, very important to bring down the neural defects. So neural tube defects means we would have seen patients with anencephaly, hydrocephalus. So all these neural tube defects can be prevented by administering folic acid in the first 3 months. And the third one was the expansion of Tdap. I already told you T is tetanus, D is diphtheria, and P is pertussis, whooping cough. So here what we use for pregnancy is acellular, that one type, that is acellular pertussis. So that is Tdap. Okay. I saw only these 3 questions.
Ma'am, good evening, ma'am. This is Vijay Lakshmi.
Vichi, please tell. Vichi,
Ma'am,
please tell.
regarding the EDT alone, just yeah. Am I audible, ma'am?
Yeah.
Yeah, we can hear.
Ma'am, am I audible?
Yes,
Yes.
Yes, madam.
You're audible.
Madam, regarding the ED span plus 7 days, sometimes when it comes in the end of the month, they should be very, very careful beyond the 25th. That alone we'll just mention it, madam. Like you gave an example of November 10th. Ma'am?
1 or 2 days doesn't matter. This EDD is the working EDD.
No, ma'am, not
4% deliver on that particular day. So the thing is, November, what he says is, suppose if it is November 28th, okay? So November 28th means, then we will add 7 days. So November 29, 30, then 1, 2, 3, 4, 5. So it will be December 5th. Then you go back 3 months. That will be September 5th. So when you add, automatically it becomes the next month.
So first you should add the days and then you should go back 3 months. Isn't it, ma'am?
That is much easier. You can also do add 9 months, but that becomes difficult. So this is much easier. You can easily go back.
No, going back,
Any question?
Yes, ma'am. What I meant was some.
I think ma'am's voice is not audible.
August, September, October, November separately. Okay, madam.
Type it in the chat box then. Your doubt?
Vijay,
For
Your doubt, type.
25th, days to it. So then
Vijay, better you type in the chat box.
August.
Type it in the chat box. We can see the type. When you
Second,
type, we can see. Anyway, next question.
so the next few questions are to Dr. Vijaya madam. One is outcome of delayed cord clamping. How safe is normal delivery for breech babies? And third one is in Don't Stop Pick, why we should not shave the pubic hair.
Am I audible?
Yeah.
Yes, ma'am.
See, the shaving, it induces damage or traumatize the skin, and it will cause infection to the follicles of the hair. The infection will spread, and a lot of scratches. And when you use a razor or a shaving blade, it damages the epithelium of the skin. It causes infection. That is why we don't shave the hair. We just clip it if it has grown abnormally. That is for the third question. Okay. What is second question? Breech delivery. You can allow for vaginal delivery, but then you should be very, very skilled in assisted breech delivery. And definitely for a assisted breech delivery is not a contraindication at all. Only if you have a footling presentation, then you have to go for a section. Otherwise, you all should be skilled in conducting a assisted breech delivery. That is an important thing you all should learn. And the first one is delayed cord clamping. Always, how much ever time you give, the more amount of blood goes to the baby, it is good for the baby, and the neonatal anemia is prevented. So always you take time, wait till the cord pulsation stops, and then you clamp and cut the cord. There is no need to hurry-burryly immediately clamp the cord and take out the baby and go and rush to the corner. The mother is the best neonatal corner. That is why.
Thank you, madam. I think there are few questions put for Sampath, madam. One was on should adolescent also take deworming tablets? Second one is what is the age limit for HPV vaccine?
Yes, okay. Adolescents only have to take the deworming. We are giving from the children itself, but once in a 6 month, even in the schools, they give the albendazole tablet once in 6 months. We have the deworming day also. That day, I'm not able to recollect. Deworming day. So it has to be given. Then the HPV vaccine, normally we tell not before 9 years. So it has to be given during the adolescent period. That is from 9 to 16 years. But we tell before the marriage, before the first sexual intercourse, they can have that HPV vaccine. Even up to 26 years. If she is going to get married when the 26 years and not have the intercourse, means she can have that HPV vaccine. Nowadays, even after the 26 years, we are telling if they are in CAN1 means we can prevent it for CAN3 like that. I don't know exactly. But now even up to 45 years, we are advising, we will restrict only to the adolescent. Before the first sexual intercourse, 3 doses has to be completed.
Good.
Okay.
Good.
In Sampath, deworming day.
Thank you, madam. I think with that end, Dr. Vijayalakshmi has put a message here in the chat box. If they need.
What is the message?
When the LMP is.
Yeah. Yes, when the LMP is 25th or later in a month, sometimes what happens? No, 2 months we are telling no. As madam told, suppose if example November 25th, then by calculating, they may, that only Vijayalakshmi is mentioning, I think. We will tell 2 months, no, November, na, October, September, then we will tell. Then it will, that is the point she is here. The ED, Shanti madam, adana solvaranga avanga.
Theriyalappa. This is what routinely we have been.
அதெல்லாம் ரொம்ப கன்ஃபியூஷன் ஆயிடும். அது 2 மாசம், இது 3 மாசம். மேடம் சொன்னதுதான் கரெக்ட். மேடம் சொன்னது
நான் சொல்றேன் அதே இல்ல மேடம் sir now let me explain sir. If it is November 25th, how they will calculate generally தப்பு பண்றது அவங்க என்ன பண்றாங்கன்னு சொல்றேன். November 25th na they are going back 3 months. November na then it becomes October, September, August. 3 months பின்னாடி போயிட்டாங்க. So they have come to August.
To add 7 days. First,
and then go back.
November 26, I've clearly said. November 26, 27, 28, 29, 30. Then December.
Ma'am, நீங்க சொல்றதுதான் சொல்றேன். நம்ம first வந்து you have to add the 7 days first. Ma'am தப்பு
போட்டுற கூடாதுன்னு சொல்றாங்க போல இருக்கு மேடம். அவ்வளவுதான், தப்பா போட்டுருக்க கூடாதுன்னு சொல்றாங்க. சப்போஸ் இப்ப நவம்பர் 25th போது ஆகஸ்ட் 3rd போட்டுற கூடாது அப்படின்னு சொல்றாங்கன்னு நினைக்கிறேன். செப்டம்பர்ல அதான் ஒழுங்கா கால்குலேட் பண்ணி போடணும். ஆகஸ்ட் 3rd போட்டுறாம. அவ்வளவுதான். ஓகே
ஓகே மேடம், எக்ஸாக்ட்லி.
அதான் அதுல நிறைய மிஸ்டேக்ஸ் எல்லாம் வந்திருக்கு. சேர வரை பண்ணிருக்காங்க. நிறைய பண்ணிருக்கு. கேஸ்ல இருக்கு. We should be careful. You should be careful. That's all.
Okay.
Especially staff nurses, take care. 9 months, 7 days. That is most important thing. Whether you calculate advance or backward, 9 months, 7 days. You add or you subtract. But please add 7 days first and then go back. Then?
Great, sir. I think with this we've come to an end. I think our assessor is also on the session, but it was such a great session, and thank you so much to all the doctors and the moderator who've done an excellent job. And I think all these doubts were also being cleared. And thanks to all the participants for participating in today's webinar, and hope to see all of you tomorrow. And day 2 webinar will be around the same time, which will be addressed by Dr. Arasar and Dr. Vijayalakshmi ma'am, followed by a group discussion by all the faculties. So looking forward to see you all in tomorrow's session. And sorry about the technical issue that was caused today because of the participation. So we will have the live links shared even before the start of the session to avoid this confusion. Thank you so much, everyone.
Tomorrow, Jayashree, can you see whether more number of people can be added? Because
I'll have to. Yeah, it is possible, sir. I'll just talk with UNICEF and get the 500 participants.
Yeah, because I have attended several meetings